And so that's why I think it was even more disappointing to see this, because we expected mRNA vaccines to perform well. But I think it's telling us important things, that in vaccine development, not every candidate is going to perform just as well, that we need to do efficacy trials to actually find out the clinical efficacy of a product, and we cannot presume just from the class of products, just because it's another mRNA vaccine, we cannot presume that all mRNAs are the same, because each one has a slightly different technology. The advantage here was, of course, that the temperature conditions were very suitable. These were to be stored at regular refrigerated rather than a very ultra cold storage. But it is a different kind of mRNA, unmodified platform. The dose used, selected for the trial was much lower than the dose that either Moderna or Pfizer had used. So I think we need to go much more in depth, which I'm sure the scientists at the company are doing, to look into the reasons why this could be so, because it will inform further vaccine development. And this is a normal process, as I said, of R&D of vaccines. We've been quite lucky to have so many successful ones, but it also underlines the fact that we need to keep on with development. We need to continue to support R&D of more vaccine candidates, particularly those which are more suitable for use at scale, storage conditions, single dose, mode of administration not being injectable, being either a nasal or an oral vaccine, and such other properties, easy to manufacture and scale. So I think each of these trials is a lesson for us also to learn more about the science, and there's so much more that we are learning about this virus. One of the key and important issues is a correlative protection, which would of course help further development and further testing of vaccines or vaccine combinations. And the WHO is leading on the efforts, again, through the networks convened by the R&D blueprint to come to some kind of consensus on correlates of protection. But at the moment, we do not have that global consensus, so it's very important that we continue with well-designed and well-conducted randomized trials. I don't know if anyone else wants to add to that.
Just add from the perspective of the challenge of vaccine development in the era of variants. I believe the company isolated 13 different variants in the study population, which again shows that the bar is being raised by the virus for this next generation of vaccines that we will need. So again, the message is that we need to use the vaccines we have, distribute them equitably, and ensure we continue to suppress transmission. The fact is that we've seen this in Brazil, we've seen similar issues in Paraguay and other countries recently, that even with the health system doing a great job to scale up its capacity, once you get very intense community transmission, health systems come under pressure again, regardless of the variant causing the problem. So again, I think we're seeing a shifting and changing landscape in which the emergence of variants, because of unchecked community transmission, is leading to challenges in the health system. It's leading to challenges in vaccine development and demonstrating vaccine efficacy. So we need to move more quickly than we're moving right now in terms of both suppressing transmission and in distributing the benefits of vaccines everywhere.
Thanks. I also want to come in on this because I do want to highlight two things. One is just the remarkable achievement that we've reached where we actually have so many safe and effective vaccines. I think we now take this for granted that we have these vaccines that are just available, and some are fortunate to be able to receive their doses. And that is because of decades worth of collaboration and investment in different platforms through the R&D blueprint for epidemics, the work on MERS, the work on SARS, really has advanced our ability to create these vaccines, safe and effective vaccines so quickly. But it does show the vulnerability that we have in this. But I have to come in on the public health and social measures. We have an amazing tool in vaccines and vaccinations, but we also have amazing tools in terms of individual level measures, in terms of societal level measures that can be tailored, that can be adjusted, that can be used intelligently. I'm not talking about lockdown. I'm talking about the use of a mask. I'm talking about physical distancing. I'm talking about improving ventilation. I'm talking about avoiding crowded spaces, making our workplaces safer, knowing what our risk is every day and taking measures to lower that risk. That has to receive the same amount of attention right now as vaccines and vaccination. And I will sit up here and be a broken record and continue to do so because we have tools that save lives right now. And unfortunately, we don't yet have the vaccines in the right places to protect people's lives. These vaccines are against severe disease and death, and they are highly effective against severe disease and death. That's what they are intended for, and that's what they need to be used for. This is what COVAX and WHO and all of our partners are advocating for, that these vaccines reach those who are most at risk for severe disease and who are most at risk because of their exposure, because they're caring for people who are sick, our frontline workers. So again, this is about the do it all in the sense that use the tools that we have. Governments need to support people in being able to do so because it's easy to say, do it, but we need to be supported in carrying out these measures because the decisions that we make today impact ourselves, impact our families, and they have consequences, good and bad. So let's continue to make good choices that we can, that we're in control of, and we need the good leadership to be able to enable us to keep ourselves and our loved ones safe.
Thank you all. Next question, Gabriela Sotomayor, Progreso, Mexico. Gabriela.
Thank you. Thank you very much, Tarek, for taking my question. Mexico cases and deaths have dropped dramatically in the last 5 months. Since late December to date, the government of Mexico City and the Mexican Institute of Social Security have had the strategy that each person who tests positive for the virus is given a kit with ivermectin for the patient and their family. In Mexico, the most populous city in the country, a study was carried out with 200,000 people, and it indicates that the use of ivermectin reduced the need of hospitalization by 76%. So I spoke with some specialists, and they say that the drop in cases and deaths cannot be attributed to the vaccine because only 20% of the population has been vaccinated. So my question is, what are your comments on this? Are you analyzing what is happening in Mexico in relation with the use of our ivermectin?
So thanks. So I could perhaps start, and others may want to come in because, Gabriela, thanks very much for your question. It's likely a combination of factors of why you're seeing transmission being reduced across Mexico. And it is indeed a very good sign that transmission is reducing and the cases are declining, and they've been declining over the past several months. I'm looking at the epi curve in front of me. And so it's probably a combination of factors that are associated with that, individual level measures that I just mentioned as well as others. With regards to ivermectin, our recommendation is for the use of ivermectin in clinical trials. Our clinical management team, led by Dr. Janet Diaz, and collaborators around the world are constantly looking at all of the studies that are evaluating ivermectin. There are meta-analyses that are being conducted that are adding more studies as those studies' results become available. And as they are being updated regularly. And then once that meta-analysis is updated, then they will look at the recommendations again and decide if any recommendations need to be changed. That's a process that we have for all of the therapeutics that are being evaluated out there. It's the consolidation of evidence from all of the different small and large trials, putting together in a meta-analysis, conducting a robust, transparent, comprehensive review, and then looking at the recommendations to see what our guideline development group can and cannot, should and should not recommend. So that process is underway, and that will be updated soon.
So I think you raise an important point, because when you look at a question about why cases and deaths may have reduced in a particular environment, as Maria mentioned, it's usually a combination of things. It's never the one intervention. So the vaccines, yes, the vaccines are protecting at first the high-risk groups, so the elderly and the frontline workers and the health workers, and that certainly has an impact on protecting the group that's been vaccinated, in which the deaths are likely to be the highest. So we know that the deaths proportionally are higher among the elderly. So if you've got that group covered, your deaths are going to come down, though infections may continue. Then you've got all the public health measures that one puts in place. And we've noticed in country after country that's had a peak and that's been able to bring it down, they've done it through a good, comprehensive set of public health interventions without ivermectin necessarily. And this, we can name a large number of countries where exactly the same has happened. So this is why just an ecological observation, early on last year, we saw similar associations being made with BCG vaccination, with hydroxychloroquine, without taking into consideration the other factors. So I think it's really important to undertake properly designed studies, and we must have an open mind, and the WHO certainly has an open mind to look at each and every intervention that could be beneficial. So there are trials going on looking at BCG to see if BCG can reduce deaths or prevent infections due to COVID, due to its non-specific effect on the innate immune system. We had a number of trials that looked at hydroxychloroquine as well as at other antiviral drugs. And there are, unfortunately, not very high-quality trials yet conducted on the role of ivermectin, either in prevention or in the treatment of disease. And this is what our guideline development group pointed out when they looked at the meta-analyses, that the studies were all of very poor or low quality. And therefore, what is needed is more evidence. So observational studies sometimes give you hints about something that could be happening, especially when you're looking at the population level where there are so many interventions going on. But what you then need are well-designed studies to prove those hypotheses. And so we encourage more research on any of these, and the jury is still out on this.
Many thanks, Dr. Swaminathan, Dr. Van Kerkhove. Now we will go to Health Policy Watch Africa, and we have Kerry Cullinan with us. Kerry, please unmute yourself and ask the question.
Thank you very much. There have been some alarming reports about the lack of, or the failure of Sinovac to prevent health workers from being hospitalized in Indonesia. And it seems like it has very limited efficacy against the Delta variant in particular. Could the WHO comment on this, and also what would be your advice to countries that are using Sinovac only? Thank you.
So I'm not aware of this particular incidents that you are mentioning, but I think you're bringing up an important issue, and that was also mentioned by Mike just now. The whole situation is so dynamic because of the variants that are now circulating, and as you said, the Delta variant is well on its way to becoming the dominant variant globally because of its significantly increased transmissibility. We need more data, again, from well-designed studies on the efficacy of the different vaccines that are in use in different countries against the different variants. So what this means is that there has to be in place a study that uses a good design. It could be a randomized trial, or if not, it could be during the rollout of a vaccine in a country. We have designs like a test-negative design, for example, and others that the WHO has actually compiled and provided on its website, different study designs that can be used to see what happens when people have 1 dose of the vaccine, 2 doses of the vaccine, how many are getting infected, and of those infected, how many are ending up hospitalized and getting seriously ill. And that kind of documentation will tell us, because again, anecdotally, one might see number of infections happening for whatever reason. If there's a lot of community transmission, there will be more infection among health workers. But are they getting ill? Are they needing to be hospitalized? And what's the proportion between the vaccinated, unvaccinated, and those with a single dose and complete dose? So this is something that we are watching very carefully and documenting, and we now have a special expert group that's been set up to exactly track the performance of vaccines and their effectiveness when used at the population level in relation to the variants. And so this also means that countries need to do sequencing side by side with documenting vaccine effectiveness. We need to expand sequencing, and maybe Maria can say more about how we're supporting countries to do that. And when we have both pieces of information, then we can start getting some solid and robust evidence on vaccine performance.
And just in general on Indonesia, there has been quite a steep surge in cases over the last few weeks. And again, as Sumia referred to before, in other countries, this is multifactorial. The number of cases has been on the rise after the end of the traditional holiday season, where millions of people move around in the Indonesian archipelago. There's a lot of travel. People move. We saw a similar phenomenon in Europe with the social mixing over the holiday periods. We think we saw similar issues in India. People move and mix, the virus goes with them, and you can get that build-up of infection. That has brought the healthcare system under some strong demand for healthcare services. And certainly in Jakarta, the hospital occupancy rates have increased to 75%, and the weekly incidence rate is up by 50%. Positivity rate is around 12–13%, which is quite high. It's not dramatically high, but there's no question that the intensity of community transmission has increased across Indonesia, particularly around Jakarta and also central Java and Kudus. And within that, the Delta variant is now becoming more prominent or more dominant in certain parts of Jakarta and other parts of Java. And that is a concern given what we've learned about the ability of the Delta variant to transmit in other areas. So there is no question that Indonesia is facing increased community transmission, increased prominence of the Delta variant, and increasing pressure on the health system, though at the moment the hospital system appears to be coping in terms of bed occupancy and strain on the system. But we've seen in other countries how quickly that situation can change. Once a peak occupancy is reached, once health systems begin to fail, they tend to fail quite catastrophically and rather quickly.
Dr. Aylward, would you like to add something?
Yeah, I just want to reinforce the importance of the point that Soumya made. Kari, when you asked the question about the alarming, you said the alarming reports of the failure of Sinovac in Indonesia. I think we want to be very clear that there are reports of people who received Sinovac actually got the disease, the healthcare workers, but that does not mean failure of the vaccine, because as you know, vaccines are not going to protect everybody who receives them. And the Sinovac vaccine, the efficacy estimate is between 50 and 76%, or in that range, as you know. So it's not unexpected in areas where everyone gets a vaccine, as we get intense transmission, there will be some cases in people who are vaccinated, but very early to say whether or not a vaccine is performing the way it should. In fact, most indications are that the rate of hospitalizations among healthcare workers overall has gone down. And even though a number of healthcare workers in this particular area had the disease, very few of them, or actually it was only a smaller proportion who were hospitalized. But a super important event, an event that needs to be fully investigated. But I think we want to be very careful about suggesting there's evidence that a vaccine is failing, because there certainly isn't the evidence to suggest that at this point.
Many thanks, Dr. Aylward. So let's go to Agence France Presse, Christopher Wacht. Christopher?
Yes, thank you for taking my question. I just wanted to come back on what Dr. Tedros said about production, and especially production in Africa. You were pointing to some news on Monday, but I was wondering if you could maybe tell us a little bit more in advance on that. We have been waiting for quite a while on the different schemes that you were trying, or not just you, but also WTO, to put into place to have more production, especially regional production in Africa. So I was just wondering if you could tell us a little bit more.
Yeah, thank you very much. We're working with some countries who are making concrete steps, and I would appreciate it if you can, have the patience. And it will also be probably a surprise for you on Monday. I would, prefer to keep it for Monday, and then you will have all the information from an African country that's taking concrete steps, as I said earlier. And also, hopefully, we will bring a northern partner also. This is a north-south partnership. And hope you will get everything from the horse's mouth from them. Thank you.
Thank you, Dr. Tedros. I think next question is also about Africa. We have it as Georgi Al-Haji from Premier Continent. Georgi, you have the floor. Hello, Georgi, do you hear us?
Allô?
Oui.
Oui, vous m'entendez?
Oui, très bien. Tu peux y aller.
Ah bon, d'accord. Gorgui Ndoye pour le Soleil de Dakar et Continent Premier. J'avais une question à l'attention du directeur général, M. Tedros. Ces derniers jours, vos services en Afrique, notamment à Brazzaville, ont annoncé qu'il y a une résurgence des cas en Afrique et qu'aujourd'hui, nous serions entrés dans une troisième phase. Comment vous expliquez-vous cela? Est-ce que les pays africains qui jusqu'à présent étaient moins touchés se sont relâchés? Ça, c'est la première question par rapport à ça. La deuxième, c'est par rapport aussi aux vaccins. On voit qu'effectivement, beaucoup de pays sont en train de consommer les vaccins qu'ils reçoivent, mais si on arrête, par exemple, avec la question de l'AstraZeneca, est-ce que la confiance va revenir? Je vous remercie.
Yeah, thanks very much. I'll start, and I'm sure others will want to come in on this. So let me first start with the first part of your question around the situation in Africa. And Africa is a very diverse continent with many countries and many populations. And so we don't want to overgeneralize an entire continent, a situation on an entire continent. But there certainly are a number of countries across Africa that are seeing alarming increases in cases. In part of your question, you said that Africa was largely spared in the beginning, but indeed many countries across the continent have had severe outbreaks, have brought outbreaks under control through this combination of factors, this comprehensive strategy. Seroprevalence studies across the continent have actually shown us that a large proportion, a proportion of the population has been infected. Seroprevalence rates of between 10, 20, 30%. Indicating that there is unrecognized cases that have occurred on the continent. And part of that is due to the lack of testing in many countries, and we are working with many ministries and with our regional office, with our country offices to improve testing capacity across the continent, in particular the use of PCR tests, the use of antigen-based tests, which can be conducted outside of labs in clinical settings by trained individuals and into communities to really know where the virus is and to carry out appropriate public health measures. But there are a number of increases in countries right now, seeing a third peak or a third wave, as you put it. And a number of countries are reaching or passing their capacities for ICU. They are reaching or passing their capacities for O2 that they have right now, and the supplies to be able to use medical oxygen for patients who so critically need it. In a number of countries, we're seeing the test positivity rate exceeding 10, 20, 30%. And so we know that there are situations where cases are increasing. We also have variants of concern that are circulating in many parts of Africa. Our ability to know where these variants of concern are circulating is limited by our ability to conduct genetic sequencing, and we're working with our African Regional Office and Africa CDC to boost sequencing capacity across the entire region so that we know where these variants are circulating. But indeed, it is a worrying situation. And remember, in parts of Africa, we're in our winter months. And in our colleagues from our regional office were reminding us that in some countries there's snow on the ground, and so people are spending more time indoors as opposed to outdoors. And we need to ensure when that happens, we have good ventilation indoors, that masks are worn, that masks are provided, that they are worn appropriately over the nose and the mouth, they have the right filtration, that our hands are clean so that when we put on and we take off that mask, that we're not inadvertently infecting ourselves, that we clean our hands. We use all of those measures. But 18 months into a pandemic, it's incredibly difficult to sustain these measures. And this is why vaccination and vaccines reaching those most at risk, particularly across the continent, is critical. And it's now that we need these because people are dying now. So we are working through our regional offices and our country offices to provide the best support that we can, and providing the supplies, ensuring that our health workers are protected, are cared for, are operating in safe working environments, that oxygen and the related supplies, medical oxygen and the related supplies are reaching those most in need, that the dexamethasone is reaching those who are most in need, used for the right patients who are severe and critical at the right doses and for the right amount of time. So it's a combination of factors that are necessary to be able to support countries that are indeed seeing some quite worrying signs of increasing transmission.
Yeah, and may I just add that it's when you look, and any of you can look on our website and see the numbers. When you see the absolute numbers, it doesn't appear that our African region is in necessarily bad shape. It's only in the last week represents just over 5% of global cases and over 2.2% of global deaths. But given what Maria said about underdiagnosis on the continent, it's trajectory that's very, very concerning. And in the last week, we've seen over 100% increases in Namibia and Sierra Leone and Liberia, in Rwanda and Zambia and Zimbabwe and Malawi and Lesotho, in Congo and South Sudan. We've seen between 50 and 100% increase in cases in places like Mozambique, in Cote d'Ivoire. So this phenomenon, and in South Africa and in Uganda and in many of these countries. So this is a phenomenon occurring across the continent. As Maria said, the factors driving it may be seasonal in the southern Africa. There may be other factors driving it elsewhere. But the brutal reality is that in an era of multiple variants, with increased transmissibility, potentially increased impact, we have left vast swathes of the population and the vulnerable population in Africa unprotected by vaccines, in a context where health systems are already weak. That's the reality. And this is the consequence of the current unfair distribution of vaccines. If we had been distributing vaccines fairly and equitably, we may by now have protected those people most vulnerable on the African continent, and we simply have not done that. And whatever the factors that are driving this, be it exhaustion in the system, be it the fact that people have to go back to work, be it seasonal, the reality is that the population that needs to be protected is not. And we have the same concerns in African countries in refugee situations at the moment. We've seen before the presumption that the next wave will be the same as the previous wave. I think every country has learned that every wave is unique because it depends on the season, it depends on the health system, it depends on the variant, it depends on the intensity of transmission. So how the virus epidemic manifests itself on each wave has been different in every country. So to assume that the next wave in Africa is just going to be a small passing shower and will not be a storm, I think is very, very premature. And I think we have to really take what's happening on the African continent very, very seriously. Our African Regional Office, led by Chidi Moeti, Dr. Tedros, and others have constantly spoken about this inequity. And we're going to pay a heavy price for that inequity in the coming weeks and months. We hope not. I dearly hope that is not the case. But the trajectory and the direction of travel and the point of impact of this pandemic is switching around the world. I've said that before. And it is very clear that there are strong signals coming from Africa and from the African region of WHO that the disease is on the rise, the impact is rising, and we need to move quickly to support those systems and get the most vulnerable people vaccinated in Africa.
Thank you very much. I see that Dr. Aylward would like to add something to this question. Dr. Aylward.
Thank you very much, Tarek. It was on the specific question that was asked about one specific vaccine you asked about in the Africa context. And of course, there's often questions and hesitancy about vaccines in general or classes of vaccine and sometimes specific vaccines. And that's the reason that there's 2 or 3 key things that are being done to try and address that with the rollout of the vaccines, because all of the vaccines that we recommend that WHO has given emergency use listing to, we've looked at very carefully and can speak to their safety, efficacy, quality assurance, and their programmatic utility. So the key things we're trying to do is get the accurate information out there so that people are making evidence and accurate-based personal decisions as well as population level decisions. The second thing that we're working toward is ensure that they're getting the information from the right channels through leaders, local leaders, other leaders, religious leaders that they know and they respect and they trust to provide that information. And of course, this comes back to the role of the press, which is just so important in helping ensure there is accurate information about these vaccines, because all of these products, the benefits far outseed the risks given the gravity of this disease and the waves of disease that we're seeing. And we're going to need a concentrated approach to help ensure people understand those realities and get themselves protected as rapidly and quickly as possible. But to the point Mike makes, and that Dr. Tedros has spoken to again and again, the big problem now is not hesitancy anywhere in Africa, many of the places we serve through COVAX, it's lack of vaccine. You can't hesitate to take something that's not available. Let's get the vaccines out there, get them available to people to help get the coverage rates up. That's the crucial thing at this point.
Thank you very much, Dr. Aylward. And with this, we will conclude this press briefing. As always, we will send the audio file later in the evening, and transcript will be posted at our website tomorrow. With this, I wish you a nice weekend, and I give the floor to Dr. Tedros for his closing remarks.
Yeah, thank you, Tariq, and thank you to all who have joined.